Hello, my name is Eric John from Spherix Global Insights, and I'm here today with a well-known thought leader in terms of the treatment of inflammatory bowel disease, Dr. Stephen Hanauer from the Northwestern University Feinberg School of Medicine. Welcome, Dr. Hanauer.
Thank you, Eric. It's nice to be here.
It's nice having you. So from Spherix's tracking of the IBD marketplace, we know that some big events may take place during the course of the next year. Specifically, which product launches do you think could impact the treatment of IBD in 2021 and maybe beyond?
Well, Eric, I think that there are actually several potential product launches in the ensuing years of several different classes of mechanisms of action, including the novel S1P agonist, Azanimod, including the possibility of a new JAK inhibitor, upadacitinib, the possibility of additional interleukin-23 antagonists, including risankizumab.
Okay. Now you mentioned a JAK inhibitor. Another JAK inhibitor that's already approved for ulcerative colitis recently released post-marketing trial data where it missed the trial's primary endpoints of showing non-inferiority to TNF inhibitors in both cardiovascular and cancer risk. What effect, if any, will this result have on any other JAK inhibitors expected to apply for IBD approval over the next year or so?
Theoretically, tofacitinib is a less specific JAK inhibitor, whereas some of the novel compounds, including upadacitinib, are more specific for JAK1 relating to inflammation and may have less off-target effects. This somewhat remains to be determined within the patient populations. As you mentioned, when tofacitinib was initially approved, it was approved for moderate to severe ulcerative colitis. And subsequently, based on the preliminary data from the trial that you've described, there appeared to be a risk factor for older patients with rheumatoid arthritis with risk factors for cardiovascular disease. Now, that is not the same as the inflammatory bowel disease population, who tend to be younger without the same risk factors. And indeed, in the clinical trials with tofacitinib in ulcerative colitis, those signals were not apparent in that population. Nevertheless, the FDA deemed it necessary to apply the restriction for patients who had failed TNF inhibitors. We haven't seen the full data set yet for upadacitinib in ulcerative colitis, including those that have been TNF naive and TNF exposed, nor do we have the full spectrum of safety. Although I will tell you, it does appear that there may be less risks for infections such as herpes zoster and potentially for cardiovascular events. But we haven't seen that data set yet analyzed by the Food and Drug Administration.
Okay, so we'll have to see what comes after those data are released.
Yes, and it remains to be determined how the FDA will continue its warnings in the setting of ulcerative colitis. Again, it's a different group than patients with rheumatoid arthritis and coexisting risk factors for cardiovascular events.
Okay. So I want to turn to another mechanism of action that you mentioned in terms of therapies and development, and that is Azanimod. And Azanimod is interesting because it is already approved to treat relapsing multiple sclerosis. We do know that in treating multiple sclerosis, the average cost of therapy per year for Azanimod is estimated to be about $88,000, depending upon, as we've discussed, contracting, bundling, and things like that. What would be the potential impact in terms of, for Azanimod, in terms of treating IBD, if it approaches, we'll say, ulcerative colitis with a similar pricing structure?
Well, the pricing is more relevant to third-party payers' prioritization rather than clinicians and patients and even society guidelines, which are independent of the pricing. The third parties are going to be interested in any distinction in efficacy between these agents. And thus far, most of them appear to be more similar than different and haven't really distinguished themselves as a more effective agent than those in other classes. On the other hand, the fact that ozanimod is an oral agent, just as upadacitinib and tofacitinib are oral agents, it will be interesting to see how a JAK inhibitor compares with an S1P agent in that setting. They appear to be relatively similar in efficacy and also appear to be relatively similar overall in side effects, although there are subtle differences between them.
Okay. It truly does look like it's going to be an interesting year in the treatment of IBD, Dr. Hanauer. Thank you so much for your time today. It's always a pleasure to speak with you, and we look forward to catching up with you again soon.
Thank you, Eric. It's my pleasure.